Good evening to all. I'm Dr. Meghana, TANWAR, and today I have the opportunity to present to you the outcomes of canaliculitis management from a tertiary eye care center in India. I have no financial interests to disclose, so although we all know that swelling of the canalicular portion of the eyelid, erythematous punctum pouting, and punctal expression of pus from the punctum are known signs of canaliculitis, but unfortunately, it's often missed or misdiagnosed. So the various management options, if you look at the trend of the treatment strategies, have evolved from previously preferred surgical options to the more conservative medical options nowadays. Now, there is no gold standard of treatment, as the ideal treatment would be one which is tailor-made for the patient. So we decided to analyze the outcomes of both medical and surgical management of these cases in our center. We looked at data from January 2023 to June 2024 and included patients with primary canaliculitis. The details which were collected were the demographic parameters, clinical details, the microbiological profile, treatment modality used, outcomes, and follow-up. So in the conservative management group, we had the intracanalicular ointment installation group, in which patients who had symptoms of less than 3 months and were willing to come for weekly visits for installation of the antibiotic ointment into the canaliculus were included. And for these patients, the microbiological sample was collected using a sterile cotton tip applicator. And once the pus had been completely expressed out, a 26-gauge sterile steel cannula was used to instill the ointment into the canaliculus. We used chloramphenicol and polymyxin B ointment, and a weekly installation was done till there was resolution of all signs, following which the duct patency was checked. In the surgical limb, the patients who had symptoms of more than 3 months are not willing to come for visits and were non-compliant from the IOI group, they were included, and they underwent punctal snip and curettage in the theatre under sterile precautions. Software R was used for statistical analysis. We had 33 patients who had a mean age of about 60 years, female preponderance, the right eye was more common, and inferior canaliculus was involved. We saw that the most common isolate was staphylococcal species, and the gram-positive being the most common. And if we look at the outcomes post-treatment, Fisher extract test revealed that the antibiotic installation into the canaliculus had more success in achieving duct patency as compared to the other two groups. So the incidence of canaliculitis at a tertiary care center previously has been reported to be about 1.4% with clear signs, but unfortunately we miss it. As in previously reported literature, we had a female preponderance with the incidence being more in the 7th decade of life, and the previously reported culture positivity rates differ between 11% to 91%, and ours was about 83%, which fell between this range. The trend of the most common isolate, if we look at published literature, in the 1990s, it was more of actinomyces. In 2000s, it became strep, and nowadays it is staph, similar to what we noticed. Focusing on the intracanalicular ointment installation group, Zhu et al. Were the first in 2015 to publish management using a specialized cannula. They used steroid antibiotic ointment, just one sitting, and they reported a cure rate of 72.7%. Alam et al. Did a similar study, but they used a plain antibiotic ointment with a sterile steel cannula and installation in the OPD itself, and they reported a 100% resolution rate, with the average number of treatment visits being 4, which is similar to our study. Yes, our study had certain limitations, as in the intracanalicular ointment installation group, it was patients with acute symptoms which we took. We did not dilate the punctum, so we could have missed dacryliths, and a few of our patients in the surgical limb we lost to follow-up. So to conclude, I'd like to say that intracanalicular antibiotic installation requires multiple visits, but it has been more successful in attaining duct patency even after treatment. Surgery can be planned for patients who are unwilling for the same, but it is known to cause lacrimal punctum pump dysfunction and canalicular block. These are my references. I thank you for your patient hearing.
you seen the effectiveness in the actinomyces group? The patients where the actinomyces was culture positive, about your ointment group?
Yes, sir. So
Ointment
we had
treatment?
one patient who was actinomyces positive in our culture group, and that is a patient who had the maximum number of visits, which were 12, and even after that, she
It
did
won't.
not. It did not resolve. So
It
we had to
won't,
switch her to the surgical.
It's not a proper antibiotic for that disease.
No, sir. No, sir. It doesn't. It didn't.
So based on the culture, you can recommend, when you can conclude that Staphylococcus group can do well with this
Installation.
non-surgical intervention, rather than saying that all the cases less than the second thing is dacrolith. Most of these will have a simultaneous presence of dacroliths.
The
So I
actinomyces group,
don't-
yes, sir.
Yeah.
Yes, sir. Thank you.